Right, good afternoon, everyone. I think we've given people time to kind of filter in, so we're just going to go ahead and get started. Welcome to the final part of our maternal and infant health data webinar series. We're really excited to have everyone here, and just a reminder that all the previous webinars for this data series are on our VNPC YouTube page, and I can drop that in the chat in a minute. Today we're joined by Dr. Melanie Rouse from, she's the Maternal Mortality Projects Manager from the VDH Office of the Chief Medical Examiner. Dr. Melanie Rouse was born and raised in Richmond, Virginia, and she received her bachelor's in biological sciences from the University of Delaware before completing her master's in health promotion and PhD in health services research from the University of North Carolina at Charlotte. Dr. Rouse has been with the Virginia Department of Health since September 2015. She currently serves as the Virginia Maternal Mortality Programs Manager for the Office of the Chief Medical Examiner. And she's also joined today by Tricia Smith, who is the Family Violence Program Manager with the Office of the Chief Medical Examiner. Tricia Smith holds a master's degree in public health, and she started at the Office of the Chief Medical Examiner 5 years ago as the Sudden Unexpected Infant Death and Sudden Death in the Young Project Coordinator. She has been with the Family Violence Programs Manager for the last 2 years, where she oversees the Office of the Chief Medical Examiner's Family Violence and Child Fatality Programs.
Tricia, go first.
Okay. Hi, everybody. Thank you for joining us today. Like Evan said, my name is Tricia Smith. I'm the Family Violence Programs Manager. I supervise the Family Violence and Child Fatality projects within the Office of the Chief Medical Examiner. So I'm just going to give you a brief insight into some of the data that we have, how we collect it, and what it can be used for. Melanie, can you put up the first slide, please? So we have 3 basic data sources for child fatality and family violence projects. The first one is the National Violent Death Reporting System, or NVDRS. Virginia participates in this. It's a national project supervised and provided by the Centers for Disease Control, the CDC, and that collects data on domestic violence, intimate partner violence, family violence, things like that. This is also probably where we would get a lot of good data from homicide and suicide fatalities for individuals under the age of 17. The child fatality projects in the state, they're 18 and under. Anyone over 17 and under, anyone over 18 is considered an adult. So we can get a lot of information from NVDRS for domestic violence and homicides and suicides. Another resource we have is the State Child Fatality Review Team. This team is much like the Maternal Mortality Team. It is this topic-specific project, though. We don't look at all deaths within the state, only on a subject that the team has selected. So we're currently doing a review of daycare fatalities, looking at several years worth of fatalities that occur in daycare. And although this is very topic specific, it also is a really thorough, in-depth examination of those cases and provide some pretty detailed data. We're very excited to recently have adopted a new system for collecting statewide child fatality data, and that is through a database that is managed by the National Center for Fatality Review and Prevention. And that is a database that we originally started using through the SUID and SDY project. And the SUID and SDY project is one that we have in the state. It is also a CDC grant funded project, and that looks at sudden unexplained infant deaths and sudden deaths in the young for children aged 0 to 19. We've participated in that project for, I think, about 8 years now. And that project used the national database for their central data repository and data collection. After using that database for a while, I realized that that might be a really good resource for us. It's very extensive. It has somewhere near 600 data points that it collects on these cases. And we have recently started to put all of our state child fatality data into that database. So it's a really comprehensive and in-depth resource for us. In addition, because we're using it for data collection on the state fatality review team and the SUID and SDY project, we have all of our data in one single repository. Can you go to the next slide, Melanie? So the benefits, like I stated, having one single national database, they have a great system set up with a good IT management and development. We have the option to modify and include specific state questions. There are multiple layers built in for QA measures, so we have high quality data. And we've been able to combine multiple child surveillance program databases into a single place. We do get quite a bit of data on these cases. The limitations to our data, not just with the national database, but all ME data, if you were to ever request data, is that it only includes medical examiner cases. And in that regard, the child fatality programs, I think, are a little bit different than Melanie's. I think she collects statewide stuff. We are limited to only medical examiner cases within the state. Child programs, like I stated, only go up to age 17, except for SUID and SDY that goes up to 19. The SUID and SDY project has very specific criteria, so not all cases qualify for that. And then NBDRS data is a limited data source just based on what they collect, and it's not very clean data, but we can work with that. Currently, there are no state domestic violence or overdose fatality review teams. Those are things that we're looking at, and different agencies throughout the state are looking at, but we do have some limited data on those if anybody is interested in. And that is all that I have.
All right, thanks, Tricia. So I'm going to talk about the maternal mortality data that we have here in our office. And we're going to start with some key definitions. So the first definition is a pregnancy-associated death. And a pregnancy-associated death is the death of a woman while pregnant or within 1 year of the end of that pregnancy, regardless of the cause of death or the outcome of the pregnancy. While a pregnancy-related death is specifically the death of a woman while pregnant or within 1 year of the end of pregnancy, that's specifically from a pregnancy complication, a chain of events initiated by the pregnancy, or the aggravation of an unrelated condition by the physiological effects of the pregnancy. And so here in our office, we do look at both of those deaths, but primarily the data that's available for release currently is with those pregnancy-associated deaths. And so we have two components of our maternal mortality projects. The first is the pregnancy-associated surveillance system. This system collects information on all the pregnancy-associated deaths in the state. It includes data from 1999 to 2021. And then we also have the Maternal Mortality Review Information app, also known as MARIA. This is a web-based database developed by the CDC to help maternal mortality review teams across the country to abstract their data, as well as document committee decisions from the case review process. It currently includes data from 2018 to 2021. Data for 2019 and 2020 is preliminary. It also includes data specific to those pregnancy-related deaths. So the Maria data is not currently available for public release because of the limited amount of data that is in there. But as more data is entered and finalized in the system, we will be able to release more aggregated data. So we currently don't have an estimate on when that data will be available. And so for the Maria system and data specific to those pregnancy-related deaths, our annual report is going to be the best source of information related to those deaths. So the case identification for both projects is the same. The difference is PAMS is a little bit more timely than the Maria system, simply because it doesn't require the full abstraction of all of the case records in order to complete the case entry. And so the way we identify our cases is first we go look for a vital record linkage. So we look for death certificates that may link with fetal death certificates or birth certificates for the year prior. We also look at deaths that are selected for women ages 10 to 60 specifically, who are residents of the state, regardless of where the death occurred. So we are able to track deaths that occur in other states as well, amongst Virginia residents. And then we look at death certificates that did not have a pregnancy check marks, well, they had a pregnancy check box marked, or they may not have had that pregnancy checkbox marked, but there was an ICD-10 code that indicated a pregnancy-related cause of death. We also identify cases through the Virginia Violent Death Reporting System. These tend to be cases where there was an early miscarriage or an elective abortion for which there is no record. We also identify cases through media reports and social media, as well as obituaries. So looking a little bit more closely at the pregnancy-associated mortality surveillance system, this system allows for the identification and the monitoring of patterns and trends related to the pregnancy-associated deaths in Virginia. The data that's included and that is available for release currently is the death certificate data, so all data related to the cause of death, timing of death, local health districts, regions, age, things like that are all available. We also have pregnancy outcomes, and the timing of the death in relation to the pregnancy is also available. Recently, we've added some additional variables to help make the data more robust. These include select health behaviors and history, including comorbidities, behavioral health diagnoses, substance misuse, alcohol abuse. We look at cigarette, tobacco product use, as well as any history of intimate partner violence, trauma, or violence in general. They also added whether or not they received prenatal care, any complications that were identified during previous pregnancies or in the index pregnancy. And so this data will be available for release in 2025. We do have some data that's available now, but not all of it yet. So we're hoping to add that by 2025. We've also added an insurance coverage data to that surveillance system, and also the safety net services utilization. So when you request data from this system, you'll be able to get more robust data that can be used. Currently, this system does not track any cases determined to be pregnancy related or the preventability of deaths. But one of the things that we have been working on is looking to add that into the data. And so we have a plan to add that into the database, and that will be available for release at the conclusion of our 2021 case reviews. So the maternal mortality review team is currently reviewing 2021 cases. And once we complete that, we'll be able to add in those pregnancy related and preventability. So you all will have that information related to those deaths. So just going over some best practices when using the maternal mortality data for various purposes. One of the first things that we really want to make sure is that we know what definition of maternal mortality you're using, making sure you understand whether you want to talk about specifically pregnancy-related deaths versus those pregnancy-associated deaths. And I talked about the difference between those two a little bit earlier. You also want to use caution whenever you're looking to compare what we have here in Virginia to national rates or to rates that you find in other states, particularly because different areas use different methods to collect these works. Across states, how we collect data on maternal mortality is very different. Some states only look at their pregnancy-related cases, while other states are similar to Virginia and look at all of their pregnancy-associated cases. So you want to make sure you understand what specific rates you're looking at and what definition is being used anytime you try to compare rates. You also want to be careful of how you handle small numbers, considering the fact that pregnancy associated deaths is a relatively rare event when you compare to things such as cardiovascular disease or cancer. It's relatively rare, so we tend to have smaller numbers, and small numbers can be statistically unreliable. So you want to keep that in mind. Anytime you're presenting these numbers or putting them in front of an audience, it's often best to use aggregated data, particularly for any graphics and tables, just so that the data still has meaning. Because data for any rates that are based on fewer than 7 deaths may be suppressed. Part of that is to protect confidentiality. Part of that is that it's just simply statistically unreliable with numbers that small. And this is just an example of some ways that you can use the maternal mortality data and present it in that aggregated form, breaking it down by race, and particularly when you're breaking down by race and other variables. So some of the merits of the maternal mortality databases that we have in our office is that it's going to be the most accurate source for data on pregnancy-associated deaths as well as the pregnancy-related deaths, simply because we go through a full process of abstracting, collecting records, abstracting everything, and ensuring that the deaths that we count as a part of our rates are we're actually pregnant within a year of their death. Data is available for release down to the health district level, and is able to provide a snapshot of maternal mortality within different regions and different health districts. And then it can also be used to help inform policy decisions. Some of the limitations with this data is that the deaths are not tracked in real time. So there's a lag of about 18 to 24 months after the end of the calendar year for the death. So it's not real-time data, so there is a bit of a delay. The data points often contain small numbers, as I talked about before, and there's a limited ability to compare these numbers with other states or national numbers. And so looking at the process to request data, we've kind of come into the 21st century a bit and finally have an online request form. Previously, we did have a paper form that you had to complete and email back, but there's now an online request form, and you can find the link on the OCME website under the Division of Death Prevention as well, or you can contact me or Tricia, and we'll be happy to send you that link. So any small request that you send to the office, we have a goal to complete within 10 business days once that request is approved. Larger requests, we'll reach out and discuss that with you prior to any approval so that we can determine a feasible timeline. All data sets will be sent via encrypted email in the file format of your choice. And we do ask that you submit any request as early as possible, as our ability to fulfill these requests within short timeframes is limited and can only be granted on a case-by-case basis. Were there any questions?
I do see one in the chat from Nancy Welsh, and she asked if there's any possibility of including if pregnant women received baby care and or home visiting.
Yeah, that is a possibility. That's definitely something that we could add into. Like I said, that will be a data point that may be a bit delayed a little bit further because it will require more abstraction and more records requests just to make sure we have the appropriate information. But that is something that we can definitely look at adding into the database. I think that would be a good idea. I see you asked if we'll be sending the slides. I can get them to Evan and I can see if they will send them out to you all.
Yeah, I think we can make that work.
Okay.
And then if there's any other questions, feel free to drop them in the chat, or you can take yourself off mute too. Awesome. Well, I think if that's it, I want to thank Dr. Melanie Rouse and Tricia Smith for participating with this. And I want to thank everyone for attending this maternal infant health data series. And I think this has been a really great series, and we really appreciate all of your participation and your feedback. So thank you so much, and I will let you have a bit of your day back.